Monday, August 28th, 2023. Topic: Malaria. Please pardon any visual and informational inaccuracies in this entirely AI-generated video.
Malaria is a serious disease that can cause a range of symptoms, from flu-like symptoms to severe complications. It is important to recognize the signs and seek medical attention promptly. Adults with malaria typically experience symptoms such as chills, fever, headache, fatigue, abdominal discomfort, and muscle pain. Children may have more general symptoms like fever, cough, vomiting, and diarrhea. The initial symptoms of malaria can be similar to flu-like symptoms and may resemble other conditions. The classic symptom of malaria is a cyclical occurrence of sudden coldness followed by shivering, fever, and sweating. Severe malaria caused by P. falciparum can lead to neurological symptoms and coma. Symptoms usually appear 10-15 days after infection. Malaria can lead to various complications, including respiratory distress, acute respiratory distress syndrome, kidney failure, cerebral malaria, and complications in pregnant women such as stillbirths and low birth weight. Other complications may include spontaneous bleeding, coagulopathy, and shock. Co-infection of HIV with malaria can increase mortality. Symptoms such as enlarged spleen and liver, severe headache, low blood sugar, and hemoglobin in the urine may also occur. Retinal whitening can be a useful sign in distinguishing malaria from other causes of fever. Malaria is caused by infection with parasites in the genus Plasmodium. The most common species that infect humans are P. falciparum and P. vivax. The parasites are introduced into the body through the bite of an infected mosquito. They then travel to the liver, where they multiply and eventually invade red blood cells. This leads to symptoms such as fever, chills, and anemia. Severe cases of malaria can cause organ damage and even death. Malaria can also be transmitted through blood transfusions, although this is rare. Malaria symptoms can come back after a period of being symptom-free. This can happen because the initial treatment did not completely remove the parasites, recrudescence, because dormant parasites in the liver reawaken, relapse, or because new parasites were introduced, reinfection. Relapse is common in P. vivax and P. ovale infections and often occurs between 8 and 24 weeks after the initial symptoms. Reinfection is difficult to distinguish from relapse and recrudescence, but recurrence within 2 weeks of treatment ending is usually considered treatment failure. Frequent exposure to malaria can lead to some immunity. Malaria infection occurs in 2 phases, the liver phase and the blood phase. When a mosquito bites a person, sporozoites enter the bloodstream and infect liver cells, multiplying for a period of time. After this, they differentiate into merozoites and infect red blood cells, causing symptoms. Some parasites can remain dormant in the liver for months or years before reactivating. The parasite is protected from the immune system by residing in the liver and blood cells, but can cause complications such as cerebral malaria. Malaria, particularly the P. falciparum species, has had a significant impact on the human genome due to its high mortality and morbidity rates. Genetic factors such as sickle cell trait, thalassemia traits, glucose 6-phosphate dehydrogenase deficiency, and the absence of Duffy antigens on red blood cells provide some resistance to malaria. Sickle cell trait, for example, causes a change in the hemoglobin molecule, making infected red cells sickle and be removed from circulation sooner, reducing the frequency of malaria parasites completing their life cycle. Liver dysfunction as a result of malaria, known as malarial hepatitis, is rare and typically only occurs in individuals with pre-existing liver conditions. However, there has been an increase in cases of malarial hepatopathy, particularly in Southeast Asia and India. When the liver is compromised in individuals with malaria, there's a higher risk of complications and death. Malaria diagnosis is typically based on symptoms and travel history, then confirmed with a laboratory test. The World Health Organization recommends suspecting malaria in anyone with fevers or unexplained fever above 37.5 degrees Celsius. Diagnosis is usually done through microscopic examination of blood films or antigen-based rapid diagnostic tests. Microscopy is the gold standard but requires trained personnel and specific equipment. Rapid diagnostic tests are easier to use but provide less information. Serological tests and nucleic acid amplification tests are not commonly used for diagnosis. The World Health Organization, WHO, classifies malaria as either severe or uncomplicated. Severe malaria is determined by the presence of certain criteria such as decreased consciousness, weakness, convulsions, low blood pressure, breathing problems, kidney failure, bleeding problems, and more. Cerebral malaria is a severe form of malaria caused by the P. falciparum parasite and is characterized by neurological symptoms including coma. Methods to prevent malaria include medications, mosquito elimination, and bite prevention. The RTS-S vaccine is licensed for use in children. Malaria requires high human and mosquito population density for transmission. Eliminating the parasite from an area is possible, but global elimination is necessary to prevent re-establishment. Prevention is more cost-effective in the long run, but initial costs are often unaffordable for the poorest populations. China has successfully eliminated malaria, while the cost of elimination programs varies between countries. Preventive anti-malarial medication can improve red blood cell levels in children with malaria-related anemia. Vector control methods, such as insecticide-treated nets and indoor residual spraying, have been effective in reducing malaria transmission. However, there is insufficient evidence that mosquito repellents can prevent malaria infection. The success of these interventions depends on factors such as the number of people using nets, coverage gaps, protection outside of the home, and insecticide resistance. Long-term prevention measures may include modifying houses to prevent mosquito exposure. Mosquito nets, especially insecticide-treated nets, ITNs, are effective in reducing infection rates and transmission of malaria. ITNs are estimated to be twice as effective as untreated nets and offer over 70% protection. The use of ITNs has saved the lives of many infants in sub-Saharan Africa. However, the ownership and usage of ITNs in African households still need improvement. Most nets are treated with pyrethroids, a low-toxicity insecticide, and are most effective when used from dusk to dawn. In areas of high malaria resistance, combining pyrethroids with piperonal butoxide, PBO, in nets can further reduce infection rates. Indoor residual spraying, IRS, involves spraying insecticides on the walls inside homes to kill mosquitoes that rest on the surfaces. This helps prevent the spread of malaria by killing mosquitoes before they can bite another person. The World Health Organization recommends 12 insecticides for IRS, including DDT and pyrethroids. However, insecticide resistance is a problem, as mosquitoes affected by IRS tend to live outdoors and are less affected by the spraying. Combining IRS with insecticide-treated nets has shown greater reductions in malaria cases. The use of additional pyrethroid-like insecticides with IRS did not provide any additional benefits. Modifying housing as a prevention measure for malaria can be a sustainable strategy that doesn't rely on insecticides. Factors like proximity to mosquito breeding sites, drainage, water supply, vegetation, livestock, and physical improvements to prevent mosquito entry should be considered. Examples of modifications include window screens and changes to the design of the home. Efforts to reduce mosquito bites and slow the spread of malaria include decreasing mosquito larvae by reducing open water sources, adding substances to inhibit their development, and using larviciding. Electronic mosquito repellent devices have no evidence of effectiveness. Fogging may have some effect on malaria transmission, but the evidence is uncertain. Hand delivery of insecticides into water bodies with low larval distribution may reduce transmission. The effectiveness of larvivorous fish in decreasing mosquito density and transmission is inconclusive. There are several medications available to prevent and treat malaria in travelers to areas where the infection is common. Mefloquine, doxycycline, and atavaquone proguanil are commonly used for prevention, with doxycycline and atavaquone proguanil being better tolerated. Mass drug administration to an entire population can reduce the risk of malaria, but its effectiveness depends on various factors. Preventive drugs are typically started 1 to 2 weeks before travel and continued for 4 weeks after leaving. Pregnant women and short-term visitors are usually given preventive drugs. Giving anti-malarial drugs to infants and pregnant women can reduce the risk of infection and complications. Prompt treatment with artemisinin-based combination therapies can also help reduce transmission. Community participation and health education strategies have been effective in reducing the incidence of malaria in some developing areas. Early recognition of the disease can prevent fatalities, and education can promote measures such as covering stagnant water to prevent mosquito breeding. These strategies are particularly useful in urban areas with high population density. Intermittent preventive therapy has also been successful in controlling malaria in pregnant women, infants, and preschool children in seasonal transmission areas. Malaria is treated with anti-malarial medications, but the specific ones used depend on the type and severity of the disease. The effects of using medications against fever are unclear. Providing free anti-malarial drugs to households can reduce childhood deaths if used correctly. However, programs that treat all fevers with anti-malarials may lead to overuse and undertreatment of other causes of fever. Using malaria rapid diagnostic kits can help reduce the overuse of anti-malarials. Artemisinin drugs, particularly in combination with other antimalarials, are effective in treating uncomplicated malaria. Artemether lumefantrine and dihydroartemisinin piperacin are recommended combinations for treating falciparum malaria. Artesunate plus mefloquine and atovaquone proguanil are also effective options. Azithromycin monotherapy or combination therapy is not effective against Plasmodium falciparum or Plasmodium vivax malaria. Amodiaquine plus sulfadoxine pyrimethamine may be more effective than sulfadoxine pyrimethamine alone. Primaquine or tafenoquine is required to clear parasites from the liver in P. vivax malaria. Quinine plus clindamycin is recommended in early pregnancy and ACT in later stages. Safety data on antimalarials in pregnancy is limited. Severe and complicated malaria cases are usually caused by P. falciparum and require immediate medical attention. Treatment involves the use of intravenous antimalarial drugs, with parenteral artesunate being superior to quinine. Supportive measures such as managing high fevers and seizures are also important. Artemisinin derivatives are effective in preventing deaths from severe or complicated malaria. There is no difference in effectiveness between intrarectal and intravenous or intramuscular quinine. The use of rectal artesunate may reduce death rates in children with severe malaria. Managing cerebral malaria involves providing nursing care, inserting a catheter and nasogastric tube, and administering benzodiazepine for convulsions. Blood transfusion and iron chelating agents have insufficient evidence of effectiveness. A recent clinical trial conducted in 2022 has demonstrated that a monoclonal antibody called MABL9-LS can provide protection against malaria. This antibody specifically targets and binds to the Plasmodium falciparum circumsporozoite protein, CSP1, which is crucial for the development of the disease. By binding to CSP1, the antibody renders it ineffective, offering a potential new approach for preventing malaria infection. Drug resistance is a growing problem in malaria treatment, particularly in Southeast Asia. Resistance to all classes of antimalarial drugs except artemisinins has emerged. However, the cost of artemisinins limits their use in developing countries. Malaria strains on the Cambodia-Thailand border are resistant to combination therapies that include artemisinins, making them potentially untreatable. The use of substandard artemisinins and exposure to artemisinin monotherapies in subtherapeutic doses have likely contributed to the development of resistance. Resistance to artemisinin and piperacin combinations has also been detected in several countries in the region. Malaria can be treated effectively, leading to a complete recovery in most cases. However, severe malaria can progress rapidly and result in death. Even with intensive care and treatment, the fatality rate can be as high as 20%. Children who have had severe malaria may experience developmental impairments in the long term. Chronic infection without severe disease can occur in individuals with immune deficiency syndrome. Malaria can cause anemia and direct brain damage, leading to neurological and cognitive deficits, behavioral disorders, and epilepsy. Malaria prophylaxis has been shown to improve cognitive function and school performance. Malaria remains a significant global health issue, with an estimated 247 million new cases and 619,000 deaths in 2021. Children under 5 years old are the most affected, accounting for 67% of malaria deaths. Pregnant women are also at risk, with up to 200,000 estimated infant deaths in sub-Saharan Africa each year. The WHO European region has been malaria-free since 2015, while the United States sees around 1,300 to 1,500 cases annually. Efforts to combat malaria have been partially effective, with a 60% reduction in deaths since 2000. Malaria is prevalent in tropical and subtropical regions, with rural areas being more affected than cities. Climate change is expected to impact malaria transmission, but the specific areas and extent of the effect are uncertain. Increased rainfall in certain parts of India and after El Niño events has been linked to higher mosquito populations. Africa has experienced significant temperature and rainfall changes since 1900, but the relationship between rainfall and mosquito breeding is complex and influenced by factors like soil absorption and evaporation rates. Recent research has used models to better understand the conditions for malaria transmission across Africa. The parasite responsible for P. falciparum malaria has been around for thousands of years, but its population size did not increase until about 10,000 years ago, coinciding with advances in agriculture and human settlements. Malaria has been referenced throughout history, with Hippocrates describing periodic fevers and the Romans associating the disease with insects from swamps. The term malaria comes from the Italian words for bad air and was once common in Europe and North America. Scientific advancements in the late 19th century led to the identification of the malaria parasite and the discovery that mosquitoes transmit the disease. There are several types of malaria, including Plasmodium falciparum, Plasmodium vivax, Plasmodium malaria, and Plasmodium ovale. Each type is caused by a different species of the Plasmodium parasite and can have varying symptoms and severity. Plasmodium falciparum is the most dangerous type and can be life-threatening if not treated promptly. Plasmodium vivax is the most common type and can cause recurring episodes of malaria. Plasmodium malaria and Plasmodium ovale are less common and typically cause milder symptoms. Malaria has been successfully eliminated or significantly reduced in certain areas, but not globally. The United States eliminated malaria through vector control programs and the use of DDT. Many other countries, including parts of Europe, North America, Australia, and Africa, have also eliminated malaria. The World Health Organization, WHO, has set goals for malaria elimination, and organizations like Malaria No More and the Global Fund to Fight AIDS, Tuberculosis, and Malaria are working towards these goals. The WHO has also targeted a 90% reduction in malaria deaths by 2030. Malaria is not only a disease associated with poverty, but it is also a cause of poverty and a hindrance to economic development. It has been linked to negative economic effects in regions where it is widespread. Countries with malaria have a significantly lower per capita GDP compared to countries without malaria. Poverty increases the risk of malaria as those in poverty cannot afford prevention or treatment. The economic impact of malaria in Africa alone is estimated to be $12 billion per year, including healthcare costs, lost productivity, and decreased investment in tourism. Severe and cerebral malaria also have long-term socioeconomic consequences, including impaired school performance and cognitive abilities. Counterfeit drugs, particularly in Asian countries, are a significant problem and a cause of avoidable deaths. The World Health Organization, WHO, has found that up to 40% of artesunate-based malaria medications are counterfeit in the greater Mekong region. The WHO has established a rapid alert system to report information about counterfeit drugs to relevant authorities. Detecting counterfeit drugs is difficult without laboratory assistance. Companies are using new technology to provide security in the supply chain to combat counterfeit drugs. Additionally, substandard anti-malarial medicines are a concern due to inappropriate concentration, contamination, poor quality ingredients, stability, and packaging. A study in 2012 found that 1/3 of anti-malarial medications in Southeast Asia and Sub-Saharan Africa failed analysis or were falsified. Malaria has had a significant impact on wars throughout history. In the Christian era, many camp fevers and dysentery cases were likely caused by malaria. During World War II, around 500,000 U.S. troops in the South Pacific were infected with malaria, resulting in 60,000 deaths. To combat the disease, significant investments have been made in anti-malarial drugs and vaccines. Organizations like the Navy Medical Research Center and the CDC have been involved in research and control initiatives. The Malaria Eradication Research Agenda, Malaria Initiative, aimed to determine the key areas of research and development, R&D, that need to be focused on in order to achieve global eradication of malaria. The University of Oxford has reported positive findings from a Phase 2b trial of a candidate malaria vaccine, R21/Matrix-M, which demonstrated efficacy of 77% over 12 months of follow-up. This vaccine is the first to meet the World Health Organization's goal of a vaccine with at least 75% efficacy. Additionally, Germany-based BioNTech is developing an mRNA-based malaria vaccine called BN-165, which has recently initiated a Phase 1 study. Unlike other vaccines, BN-165 is being studied in adult age groups, making it potentially suitable for Western travelers as well as those living in endemic countries. Malaria parasites contain apicoplasts, which are organelles related to plant plastids. These apicoplasts have their own genomes and play a crucial role in parasite metabolism. Over 400 proteins produced by apicoplasts are being investigated as potential targets for new antimalarial drugs. Synthetic pyridoxal amino acid adducts and metal-based complexes are also being explored as strategies to combat drug-resistant Plasmodium parasites. Experimental drugs like Plus SJ733, NITD 246, and NITD 609 have shown promise in inhibiting proteins involved in malaria infection. Molecular docking analysis has identified compounds with selective and potent inhibition of PFLDH, an enzyme essential for parasite survival. Researchers have identified genes and metabolic pathways that are essential for the liver stage of the malaria parasite Plasmodium burgii. By using knockout mutants in a computational model, they found that fatty acid synthesis and elongation, amino sugar biosynthesis, and other metabolic pathways are crucial for the parasite's development in the liver. These findings could help in the development of new antimalarial therapies that target these metabolic proteins. Advances in genetic engineering have allowed for the development of non-chemical strategies to control malaria mosquitoes. This includes genetic manipulation to decrease the mosquito lifespan or make them more resistant to the malaria parasite. The sterile insect technique involves releasing large numbers of sterile male mosquitoes to reduce the wild population. Genomics plays a central role in malaria research, allowing for the study of the genetics of the malaria parasite, mosquito vectors, and humans. Genetic modification of mosquitoes to prevent malaria transmission is also being explored. Co-infection with certain parasites has been found to reduce the virulence of the malaria parasite. There is also a correlation between malaria endemic regions and lower COVID-19 case fatality rates. Recent research has identified genetically modified bacteria that can prevent malaria in mosquitoes. While most malaria parasites that infect humans do not have animal reservoirs, there are some species, such as P. knowlesi, that can infect both humans and non-human primates. There are also many Plasmodium species that infect birds, reptiles, and other mammals, including non-human primates. Some of these parasites serve as models for human malarial parasites in research. Malaria parasites that infect rodents are also commonly used as models. Avian malaria primarily affects birds of certain orders and can pose a threat to certain bird populations, with global warming expected to increase its prevalence. In conclusion, malaria is a serious disease that can cause a range of symptoms and complications. It is important to seek medical attention if you experience any flu-like symptoms or suspect you may have been infected with malaria.